this evening. So good afternoon and welcome everyone. This is our 7th installment of the Election 2020 Lunch and Learn series. My name is Emily Sears and I am the Civic Engagement Fellow for Queen's University of Charlotte. If you have any questions during the presentation, please feel free to post them in the chat box and I will ask them to Dr. Rucker when we get to our questions section. Be sure to also follow us on Instagram at QU_votes to keep up with everything that we are doing. And before I introduce Dr. Rucker, I briefly want to mention that there is an online event going on tonight called Fragile Democracy, and it's sponsored by the Wells Fargo Center for Community Engagement and the Stan Greenspon Center for Peace and Social Justice, and in addition to other Charlotte faith and social justice organizations. This will happen at 6:30 p.m. tonight, and you will hear from panelists who have experience working across transnational movements and who will discuss the parallels between media literacy and democratic participation, in addition to how we can appropriately evaluate disinformation and protect our voice. And you can sign up in the Eventbrite link that Jen will put in our chat. Now, to get to what we've all come here today to hear about, Dr. Susan Rucker is an assistant professor in the Master of Health Administration program at Queen's University of Charlotte. She has more than 35 years of healthcare leadership experience in areas that progressed from hospital administration to consulting to graduate level teaching. In all of her professional and volunteer endeavors, she uses her experience to highlight and mitigate health disparities. In 2000, at the Medical University of South Carolina, she achieved the honor of being the first female in the U.S. to earn a doctorate in health administration. Dr. Rucker has also worked in higher education since 2004 while maintaining a few consulting clients. Dr. Rucker has achieved the Fellow of the American College of Healthcare Executives credential, which is the gold standard for healthcare competency, knowledge, and commitment. So Dr. Rucker, thank you so much for being here, and I will turn it over to you.
Well, thank you very much. I look forward to your comments. So I've made the presentation a little bit shorter so that we could have some time for discussion and questions afterwards. So healthcare in the 2020 election. One of the things that I wanted to point out is that registered voters were asked to rank 3 issues, and healthcare came out as the #1 issue. And I think that's just very important to focus on. What we're going to cover today is a little bit about the history of healthcare and politics, second healthcare plans, and then Obamacare, which is the ACA, versus Trump care, how to evaluate a good plan, and then leaving time for questions and answers. So the outcome that I'd like you to be able to do is be able to evaluate what the healthcare proposals are out there and how they match what your interests are. So history of healthcare and politics, it continues to be a top priority. And it has been, and as far as my knowledge goes back, I mean, I could Google this, but I don't want to give you the whole history of healthcare in the United States. But Medicare has been on the political agenda since 1945. And I color-coded these for Democrat and Republican. So you can see where Medicare for all, or in some rendition of it, has been part of the political agenda all along. And it has been having bipartisan support. And if we get down to today, we still have bipartisan support of some kind of a health care. But every time healthcare came to the forefront and Medicare came about, it was put down by lobbyists. So it's not the American people that have voted out major healthcare reform or brought in something that's more equitable. It's the lobbyists who have fragmented the system and created compromises that really took apart what was truly intended and took apart what was really a comprehensive plan. So where does that leave us in the United States? Well, it leaves us with the United States spending more on healthcare per capita than any other country. But what I'd like to point out is if you take out the private spending, which is our insurance companies, we're really kind of in line. And that's an important factor because this is this is where we differ from these countries right here, is they don't have private insurance companies and we do. And that's the excess cost. But here we have the highest cost, but we have the lowest life expectancy. And there are a variety of reasons for that. And one of the primary is the lack of uniform access. So back in 1940, almost everybody was uninsured, had no access to health insurance. After World War II, wages were frozen, and the only way they could entice people, corporations could entice people to join their company, was to offer a benefit, and that benefit was health insurance. And that's where you see this major dip, where people continually got health insurance through their employers. Where it dropped the most was where Medicare and Medicaid came in. And I could go back to the previous slides and point out politically in that timeline where that happened. So right away, we got a lot of people insured that had never been insured before. But because of prices escalating, fewer people could afford it, and more businesses could not afford it. What happened right here, where there was another massive drop, where more people got insured, and that was the implementation of the ACA, the Affordable Care Act. However, because it's largely private insurance companies, they haven't made, when they didn't make enough money, they increased the prices. And what that did is it's starting to climb again because people again cannot afford their health insurance. Because everyone is not covered, and because coverage isn't uniformly provided between employers, we have a lot of racial disparities. Rates for lung cancer, heart attack, kidney transplant, outcomes are far worse for people of color than they are for whites. And just to point out a couple others, life expectancy, there's an 11-year gap. Latinos, 1 in 6 have difficulty finding specialists. More live below poverty level and tend to be uninsured. Blacks have the highest rate of new cancers and the highest death rates. And I think most of us know about far worse maternal outcomes. And all of this has to do with how our system is set up. So if we look at the 17 advanced countries, and they're listed down here: Australia, Canada, Denmark, Finland, Germany, Italy, Norway, Spain, Portugal, we have the lowest life expectancy and the worst health outcomes until we reach age 65. And magically at age 65, instead of being ranked 17, we continually go up in rank. And what happens at age 65? Medicare. So at 65, when we have universal coverage where everybody has access to the same level of health care, our expectancy goes, our outcomes go up, our health goes up. And I think that's a critical factor in considering what kind of health reform you want to look at. So this is the grand experiment of the 70s, and this was part of my career. So in 73, we signed an HMO Act into law, and that is a health maintenance organization, a type of an insurance model. But what Medicare did, what Canada did, is they signed in the Medicare for All. And that's one of the proposals that is still on our table today that still gets voted on and taken apart. But this Medicare for All, and look what happened with the Medicare for All. When they implemented that and we implemented our HMO Act or expanded private insurance, our costs continued to escalate at a far higher rate than they do in Canada. And I think that's a very significant thing to point out is, where does this money go? Does it actually go to treating people, to diagnosing to preventing diseases? And the answer is no. Most of it goes to private corporations. So I anticipated that there would be a lot of students on here, but just to point out, if I have a salary of $40,000, I would have $8,000 taken out, bringing me down to $31,000. Health insurance for two people averages $1,000 a month. I'm down to 90%. So if we called our health premiums taxes, we would be at 50% or more tax rate. But what puts us at a more vulnerable situation than other countries is that with this plan, you could have a $12,000 deductible, meaning every single year you are at risk for paying $12,000 before insurance really kicks in. And then it kicks in with where you have a 20% copay. So you look at, this is what you have to be ready to spend, and this is your income. And it doesn't leave a lot. And there are other vulnerabilities with having your health insurance tied to your employer. So we'll go over those in a little bit. But I want to talk about healthcare plans. So there's basic health insurance, and that's what most people have when they get their insurance tied to work. And it guarantees coverage. And that's a new thing, but hasn't always been there, where it didn't cover pre-existing conditions. So that's our traditional Blue Cross, Blue Shield, Cigna, Aetna, United, where there are copays, deductibles, and most of the overhead in those types of corporations is about 30%. So then Obama brought in the ACA, the Affordable Care Act. And one of the things to remember is this was not what we have is not what he originally proposed. What he originally proposed was something far more equitable and comprehensive. But what we got is a lot of compromise and a lot of lobbyists to take things apart. But what the ACA did give us is guaranteed coverage, no pre-existing conditions where could rule you out of insurance. Things became essential benefits for everyone, and there were preventive screenings covered with no copay or deductible. So that meant for the first time, prevention had to be provided without any copay or deductible. Annual lifetime maximums were gone. I don't know if a lot of you know that was a significant problem during my life in insurance, where there would be caps on certain diseases, caps on certain procedures. So once you hit that was considered your lifetime maximum, and you were done. You could never tap into that again. And for people with a chronic disease, that's not only cruel, heartbreaking, it's not fair. The ACA also brought us a regulation where if you got sick, you couldn't be dropped from having coverage. A really great thing for students is that they got to stay on their parents' policy until they were age 26. Just by doing that, millions of people got access to healthcare instantly. The ACA has subsidies for low income, and it has different plans that people could opt into. One of the big things and controversial things was the individual mandate. Originally, the ACA came out and said every single person has to have insurance. Otherwise, there's a financial penalty. And that became a political battle where, is that constitutional? Why are we doing that? Well, the reason why is to make a comprehensive healthcare system work, everyone has to be in it to share the risk. It prevents corporations from saying, we will only insure the healthy people, the people who work out, the people who don't have hazardous jobs, the people who don't live in an area that has high pollution. And we call that cherry picking. It also prevented insurance companies from lemon dropping, which means dropping the diagnoses, the procedures, or the patients that cost a lot. So another mandate from the ACA was 80% of the premiums must be for healthcare coverage. That means 20% was allowed to go to overhead. And I don't know about you, but that is very, very high. And if we compare that to what Medicare has traditionally run under, Medicare operates at almost a 3%. Really, it's 2.5, but we'll round that up to 3% overhead. And here it's 20% and can go up to 30% in other types of markets. So this is just looking at the number of uninsured and the uninsured rate among non-elderly under 65, but over 18. And we see we have millions of people who don't have access to basic health care, which is a heartbreak. And why do people not have access to health care? Sometimes it's a loss of a job. It's the inability to do a job because of an acute illness that you could recover from. But when you don't have health insurance, you don't get access to care. So by not offering comprehensive health care, we create the need for safety nets in other areas to cover disabilities that happen, homelessness that happen, bankruptcies that happen because there isn't adequate health coverage. So I changed that before and it just didn't change here, huh? So traditional Medicare, unless you're my age, you probably don't really know that much about Medicare. So Medicare has several different components. It has, if you're on traditional Medicare, and the reason why to have you know a little bit about Medicare is because Medicare for All is one of the major platforms that's out there. A covers hospital, home care, skilled nursing care, and hospice. B covers the doctor's office. So one is the hospital, one is more the doctor's office and testing. They don't get advertised on television. What you see getting advertised a lot on television is Part C, the Medicare Advantage plan. And that's an experiment where health insurance companies said, we're missing out on all the people over 65, the opportunity to insure them. So let us offer a private plan. Well, Medicare Advantage plans put a large portion into overhead, not the 3% that the A and B does. And they do that by limiting a network and cherry picking patients. It's only better for you to go into Medicare Advantage if you are pretty healthy. I mean, really healthy. If you get a serious illness, you can't go back and go into A and B. And then there's D, which is for prescription coverage. If you have A and B, you need to get C, which covers things that aren't normally covered. Now, think about this. This is enough to make your head spin. In other countries, you have a card and you walk in and you give them a card and you get your service and you don't have to worry about all this stuff, which is really crazy. Okay, so what improved Medicare for All, and a lot of people call this the Bernie Sanders, the Jayapal, or it's House Bill 1384 talk about, is they want to take this 55-year-old plan of Medicare and make it better. And because it does, remember that chart where it goes up, you know, quality of life, life expectancy, health outcomes, to take that and give it to everybody across the board at all ages, all income, all jobs, is to build on this plan and what is good with it. Take out what's not so good and give it to everyone. So there would be what they say is not good. All right, there are still co-pays, deductibles, and this supplemental insurance with Medicare. So Medicare for All would take care of that. Obviously, since it's taking on younger people, it would add reproductive, maternity, newborn, and pediatric care. But on the other end, it would also add long-term care. So you don't need all those other things. A and B would cover it all. It would be non-profit, which means lower administrative costs, and it would include lowering drug costs. So right now, drugs are not, the price of drugs is not negotiated. So I have a friend who is he's into politics. He takes people across the border into Canada to buy drugs and come back because they can afford them there. But the funny thing is, the drugs were made in the United States, shipped to Canada, and people go to Canada to buy them cheaper than they can buy them in the United States, because we don't negotiate drug prices. If we could negotiate drug prices down to the same level that other countries have, we would have tremendous cost savings that could go into prevention, diagnostic, treatment, healthcare coverage. Again, cover all pre-existing conditions. And this is something you may have heard in the media, where COVID might be considered a pre-existing condition. And that's a big fear for a lot of people, is we have to maintain that everybody gets coverage regardless of pre-existing condition. And this would be tax-funded, government financed, just like Medicare is, but it would still give private and delivery. And everybody would be in network. So every single physician that is part of Medicare would be participant. I wouldn't have this small network. So the public option sounds really good, but where it's not as good is that it still has that one layer additional of health insurance. So where they say it's going to save money, it probably won't, and it offers just that additional layer of complexity. So it is funded by taxes. Each state would have the ability to do something different. So people in California might have better coverage for this disease than somebody in Indiana, and you would have to play games and actually move to states that would cover things, which is similar to the situation we're in now, where in North Carolina didn't expand Medicaid, and people have had to move out of North Carolina to other states that did expand Medicaid. The public option would lower the age of Medicare to 50, cover pre-existing conditions, but where it's different is it's not mandatory. So again, we're missing that risk pool, and that's where insurance companies, they want this opt-in, because then they can select who they get into their plans. Private insurers still exist, and it's tax funded. So comparing the Medicare for All versus the public option, you can look down there and you think, yeah, it has a lot more whys, so I think I'm going to go with that. You have to think, are those whys really good things for the country, for society? Is it something that you want? So the biggest thing is here, because it's not opt-in, Medicare for All is for everyone, that actually creates the sustainability of having that risk pool again, and not where everybody gets the equal coverage. It's not some people can opt out because they have more money, because they're healthier, because they're younger. Low income, pre-existing conditions, tax funded, very, very similar. Competing plans, no, there wouldn't be competing plans, because there would be one plan with a big risk pool. And this to me is the largest in my criteria. I want everyone covered. So to me, that's very important. Again, the public option, we cover you if we can make money. So now that we've talked about plans, let's talk a little bit about what the political candidates are standing on. So one of the things that we can't totally separate from healthcare is the environment. So fossil fuels have been deregulated. They've declined 24% from 2009 to 2016, with particulate matter going up. What does that mean? And why do we have to worry about other policies in addition to healthcare policies? Because with that deregulation, we've had 10,000 deaths per year attributed to particulate matter and deaths related to that. So while I'm talking about healthcare, we have to also embrace other factors, and that's just one factor. So I tried to make this in red, but it was too hard to read. So this is in what the Trump platform proposes. People in rural states will have the highest burden of costs on healthcare. The Trump platform puts a cap on Medicaid funding, putting essential care at risk, meaning if I'm this level ill, I'll have coverage. But if I need more, I don't get it. So there's no coverage here because of the cap that's been placed on. And then the other is the Trump platform replaces the ACA's income and premium-based tax credits with fixed dollar credits that they kind of adjust on a formula that includes age. But by no longer adjusting your tax credits for income, it causes people below the 200% poverty level to pay thousands of dollars more for the same healthcare coverage. So what it's doing is putting an undue burden on low and the most vulnerable populations. And so a lot of people are saying it's really not health reform. What it's doing is changing tax credits, and those changes in tax credits impact how health is provided and how people can afford to access health care. So premiums for young adults would be higher because of the tax credit. Political platforms, so I broke this out into different parts of a political platform. So I put Trump on the left and Biden on the right. So recently with the pandemic, Trump has we are no longer associated with the World Health. The United States has pulled out of that, and he's changed how information is reported to the CDC. Biden would reverse that and put us back into the World Health Organization and funnel information back to the CDC as it has been done for decades. There's a lot of information out there how Fauci, that Trump has gone against what the scientists say as far as vaccines, wearing masks, prevention. And Biden is going to put science first and the health leaders first and have them define policy. Each state is responsible for the pandemic and pandemic response, where Biden makes it more of a federal government response. In other words, a global access to resources, such as ventilators, protective equipment, funding. Trump signed into law the relief for COVID-19, the financial relief. And Biden supports expanding testing equipment and pay and income protection. One of the things I want to point out with is in our current situation, if we look at how we compare to other countries and our healthcare plans, the US is only 4% of the world population, yet we have 25% of the cases and 22% of the deaths. Why is that going on? And is there something we can do to fix that systemically? Another is the Affordable Care Act. So Trump has replaced the Affordable Care Act with a weakened protection. In other words, the ACA said, we have to offer all of this to all people at all times. That's what we do. Trump is saying, oh, we'll let insurance companies cover just this. Biden wants to build on the ACA by creating more Medicare-like options for low-income people. What I call junk insurance is the insurance that you pay a lower amount for, but you're taking a gamble because it only covers these things. So as an example, my daughter was in between jobs for 1 month. She had a month without health insurance. Unfortunately, I went and bought her junk insurance. It was the cheapest alternative because it was unaffordable to pay for 1 month. My daughter's perfectly healthy, but it didn't cover any pre-existing condition. It put a cap on every single broken leg cost this amount, whether that was broken through the skin, needed to be surgically set or whatever. Those are what we call junk insurance. And they put people in a very vulnerable position when they think they're in a more secure situation. Biden wants to reduce the age for Medicare to 60, which would expand coverage for millions of people. Trump eliminate financial system in a place with grants. So grants have a cap on them. So it says that we're not going to offer everybody, a certain percent of a subsidy. So it's unpredictable and it varies between state, and it can come and it can go because it's a grant. Biden is offering more assistance to the state. That's a hard one to compare. Under Trump's plan, sicker people will pay more for their insurance, and that doesn't happen in the Biden plan. Biden plan offers more choice to people, a more open network versus a closed network, and it reduces complexity. So when you think of complexity, it reduces waste. Anytime there's, you make things more simple, you take away waste and the costs associated with that. Prescription drugs. Trump put insulin, he capped that for some people. So there's a cap on the price for insulin for people on Medicare, but it is not for people who are under Medicare age. Talked about limiting prices and getting other companies to work on pricing. There hasn't been action yet, but that would be great. Biden wants the government to negotiate drug prices. He wants prices to be capped, that we would pay no more than what other countries are paying, which right now it seems funny that a drug that we did the research and development on and paid for, and most of that came from our government funding, that drug is sold in another country for a fraction of what it is sold for here in the United States. He would cap out-of-pocket costs for Medicare and allow consumers to import drugs from other countries and eliminate drugs advertising tax breaks. So one of the reasons why drug companies advertise so much is the cost, the money that they spend on advertising, they get a tax break on it. Other companies may not get that. Reproductive health. Trump wants no federal funds for family planning or to any organization that provides or refers to abortions. And that's internationally as well. So to think deeper about that is, if I go to a federally funded clinic and I want to have an abortion, whether you believe in it or not, the doctor's not allowed to discuss or refer that. And if they do, they lose their funding. He wants to repeal anti-discrimination provisions and overturn Roe v. Wade. So people who vote on a single issue, this is a huge issue, and probably the most vulnerable in the healthcare. Biden wants to overturn, provide federal funds for all people, and supports anti-discrimination for LGBTQ. So right now, if I were a transgender person and I had, let's say, female to male, I would still need to have a check for ovarian and uterine and cervical cancer if I still had those parts. That's not covered under insurance right now. So it would pull all of that together. Biden does support Roe v. Wade. Immigration and healthcare. In the restriction of DACA means that the people that are in DACA would have, those restrictions would be put into place. A wall, eliminate the lottery for entry, restrict non-cash benefits for things like Medicaid, and deny new immigrants insurance status. Where Biden would reverse DACA, he's not for the wall, and would provide a roadmap to citizenship and remove the 5-year wait. So right now, if a person comes into this country, there's a 5-year wait for a child to get onto Medicaid and CHIP, which is the Children's Health Insurance Project. And he wants people who are unauthorized to still have health insurance. Now, what you need to think about here is the big picture. So in areas where there have been immigrants who did not have access to any health insurance, they had measles outbreaks. Well, those things affect everybody else. So can you draw a line and say, you know, we own, you know, put a bubble around certain things? And then it's like air quality. We really can't. It affects everybody. So to think about the logistics of where you draw that line is very important. How do we evaluate a good plan? So,
Dr. Rucker, I'm sorry, it's Jen. I'm going to just give you a heads up. We're 8 minutes over. So if I can give you a couple
I'm
more.
so sorry.
That's okay. And we have a question too. Are you at a place where I can give you 2 more minutes to wrap up, and then we can ask you a couple?
Actually, I had one more slide.
Perfect.
And measuring candidate health plans. So the things I look at in a health plan is coverage. Does it guarantee all lifelong coverage? Is everyone coverage in all parts of the body? And do I have a free choice to everybody? The other is, does it reduce healthcare costs, not just for me, but does it drive overall costs of the healthcare industry down and eliminate these out-of-pocket expenses, which cause people to go into bankruptcy? You know, I get sick, I can't work, and I have no health insurance. So then I end up losing my home. You know, control drug prices. And really the biggest one for me is outcome and equity. Instead of having corporations divide up and select to make profit, I like everybody to be covered so that we can have reduced racial disparities and improve health outcomes for everybody. And that's the end.
Awesome. Thank you so much. I'm sorry to interrupt. One of the questions that we had is, Trump has spoken about a new prescription drug policy that becomes active on January 1st of 21. He referred to it as the favored nation status, which gives the U.S. the ability to lower prescription drug prices. Are you able to talk a little bit about this policy?
I'm not able to talk too much about that because it comes and it goes. But he's tacked on to what the Biden proposal is, that we shouldn't be paying more for our drugs than other countries are paying, is kind of the bottom line. So I didn't bring that up in, let's see, prescription drug prices, what was that? Anyhow, there isn't a lot of meat on that bone to be able to talk in detail about it. But he's brought that out, that be able to not pay more than others. That's still not negotiating with drug prices.
Okay, thank you. The other question that we had was, other countries make their access for all health coverage more affordable than the marketplace system did. The ACA was still obtainable for many, so was our ACA program really helpful and truly access for all?
Was it, you broke up there, was it really access for all? Is that what you said?
Yes, ma'am.
Okay. No, it wasn't access for all, because still a lot of people could not access healthcare with the ACA. So for the first time, millions of people could finally afford it because there were subsidies. But those subsidies were so convoluted and fine that I'll tell you a situation that happened. I was consulting for this corporation that employed a lot of people that finally got to get their healthcare with the ACA. And they got subsidies because they were low income. Well, the company decided to reward people with gift cards and financial incentives for doing a good job. Because that bar was so fine, a $20 bonus cut them off, that they were no longer entitled to health insurance subsidy. And so that meant at the end of the year, people who thought they could have, that they were getting subsidy and pay health care, had to retroactively pay for all of their health insurance because of a $25 gift card. that's almost having to, for bankruptcy. So the complexity of the ACA is not what was intended, but it was as far as we could go in that administration. The good thing was, to me, is it covered more people. And anytime we cover more people, we have a more equitable system.
Okay, I have one more question. Do the racial disparities improve when Medicare coverage is on board for 65 and up?
Yes. In fact, I have a slide that I've done in another presentation where you have all these disparities in all different industries, diagnoses. And the minute there is uniform coverage, and where do we have that? In the VA. In the VA, every single person in that system has the exact same coverage and access. And guess what we have? No disparities. So providing universal coverage to everybody, the same care, of the disparities. There are things we'll have to work out. For example, how to get really rural areas good access to healthcare. But we have technology now, and there are things that we can work around. But the thing that's most important to me is to put people before politics. We've been fighting over this my entire life about a single-payer healthcare system. And think about how many millions of people suffered needlessly because they didn't have access to universal health care or a healthcare plan.
Well, I keep getting this amazing feedback from your presentation, and people are telling me that they could listen to you go on and on. It's very fascinating and hard to get information. So I want to remind you all that we do post all of these sessions on the QU Votes website. I put them in the chat, that website in the chat earlier. And I want to thank all of you for attending. Special thank you to you, Dr. Rucker, for sharing your knowledge with us. It really is hard to get information, and this was a wonderful way to walk us through so we can actually understand what is going on with all of the healthcare disparities and healthcare plans. Next week, we are talking about immigration policy with Dr. Maggie Commons from Political Science Department at Queens. And please remember, early voting, you've heard this everywhere, but it is up and running. So if you need access or are unaware of where to go in Mecklenburg County, visit our website, and we will we have a list of all the different postings of where you can go early vote. If you have voted already, thank you. If you haven't, plan to do so. Thank you so much, everybody. Have a wonderful week. We'll see you next week or tonight in the program. Thanks. Bye.
Thank you. Thank you, everybody, for attending.
Thank you.